Welcome back, everybody, to another episode of Outside the Box, and I'm with my good friend Ernie Dickson. Ernie, how's it going?
I'm doing great.
Ernie, as you guys know, is with Elite Physical Performance. He's in our. Are you just in Kingsport or are you in Johnson City as well?
I'm in Johnson City some. I'm mainly in Kingsport most of the time.
Mainly in the Kingsport office. So he's a familiar face. He's been on the show quite a bit. And we've got a really interesting topic today. And I want to get just some background is on shoulders. So tell me a little bit about shoulder injuries and kind of what people need to be looking out for right now.
Okay. The thing I was going to talk on today is actually what they call shoulder impingement syndrome. And it kind of incorporates several things. It kind of incorporates the rotator cuff tendons, the bursa. A lot of people that I see in the clinic, they'll come in with a complaint of shoulder pain. And they usually will say, it hurts in my shoulder. It hurts when I raise overhead, my arm overhead, or reach behind my back, or I sleep on that shoulder. And most of the time, it's sort of an impingement. And what that means is there's a space between the acromion, which is part of your shoulder blade or your scapula, and then the humerus or the long bone here, the one we always associate as being the shoulder.
Okay.
There's a space in there, and the rotator cuff tendons lie in that space. The bursa lies in that space. Part of the capsule lies there. The long head of the biceps tendon. So that space between the acromion or the scapula and the humerus is what you call the subacromial space. And that's where the impingement occurs. So it's kind of a mechanical impingement.
So what is an impingement? When I think impingement, I've always thought of like a nerve, like you've got an impinged nerve or something.
Right.
So an impingement is a space?
Yeah, it's kind of like any, if you had a space and it's closed down, then you would call that an impingement. So you could have an impingement on a tendon or any structure really. It's more that structure lies within a space and there's getting some closure on it.
Okay.
And you're getting pressure or friction on it is kind of what it is. It's kind of a term they use. It doesn't mean, you could have some tendonitis and bursitis and that's all it is. Or you could even have a little tear going on. Or you could have a capsular issue or a labral issue in the shoulder. So it doesn't tell you specifically what it is, but it's kind of referred to as like a syndrome.
Okay.
And so when you see the therapist or the doctor, they evaluate you, and then you can tell whether it's more tendonitis, bursitis, is it a labral tear or a rotator cuff tear, or is it just adhesive capsulitis? But the overall diagnosis sometimes is just called impingement. It's sort of a generalized. It's almost like someone has hip pain.
Yeah. Got it.
That kind of thing.
Is it specific to the shoulder impingements?
No, you can have some
impingements
joints in other areas, but mainly, with the shoulder, it's real common because you see it a lot in. You see it in athletes, your overhead athletes, the tennis players, baseball pitchers, quarterbacks, swimmers.
Oh yeah.
That kind of thing. Plus, you see it in just the general population because. If you have to do a lot of repetitive reaching, somebody that does a lot of painting, like painters, or even just doing everyday things. Say you're lifting and you're out in the garden and you're doing a lot of digging and things like that.
So it's called shoulder impingement syndrome.
Right.
Okay, and what I'm gathering here is basically you come down with this through overuse. I'm a tennis player. I've had a lot of overuse injuries just because of the repetitive, often one-sided, like with a tennis player, if I'm right-handed, I'm doing a lot of things on this side of my body, a lot of overhead, etc.
Right.
I very easily could get a shoulder impingement on my right shoulder.
Sure.
One thing you mentioned before we started recording is there needs to be balance, between, like in terms of like what you work out. So like, how would somebody protect themselves from this and how would they recover from shoulder impingement syndrome?
Right. The cause of it can be several different things, and it probably helps to go over the anatomy of the shoulder a little bit.
Yeah, let's do it.
There's several things that kind of that kind of influence that space in there. there's different types of acromions, and it's something that we're kind of born with. Like there's a type 1 or type 2 or type 3. A type 1 acromion would be just the normal shape of the acromion. So, with that type of acromion, you have a little bit more space between the humerus, the head of the humerus, and the scapula, or the acromial part of it. A type 2 is a little bit different shape. It has a curve in it.
Hmm.
So you have less space between the joint there. So that's where the tendons and the bursa and the capsule lie. So someone that has a type 2 acromion would have less space naturally just because of their anatomy. It's not anything that you can do. It's
Got it.
something. And then a type 3 actually has a little hook on it. And so they have less space. It doesn't mean they're going to have impingement syndrome, but they're a lot more likely to. So that's something that is there, and it's not anything you can control. But sometimes people will say, well, I've got a type 3 acromion when they go see the doctor. So it just means that they've got more of a predisposition for it. It doesn't mean they're going to have it. But the thing we see a lot of that people have impingement is there's an imbalance. Usually they have some weakness in the rotator cuff muscles.
Mm.
The function of the rotator cuff muscles a lot of times, especially when we raise our arm overhead or out to the side, those rotator cuff muscles pull the head of the humerus down, and that gives you more space. But say you're doing a lot of repetitive overhead things and you have weakness in the rotator cuff, well, the rotator cuff's not pulling the humeral head down, so it gradually rides up under there, and then you get the friction, and that's where the tendonitis comes from and the bursitis. So you can have rotator cuff weakness that allows you to start to get that impingement. And then the other part is we tend to be overdeveloped in the muscles in the front of our body, like our pecs, our biceps. We tend to do a lot of work with those, and those all sort of pull the scapula forward. So, the scapula is sitting on the chest wall, on it's over the ribs on the back. Well, if those muscles in the front are tight, they pull the scapula around the wall of the chest wall there.
Okay.
And it's called protraction of the scapula. So when the scapula is protracted, there's less space in that subacromial space there. So that sort of predisposes you to have more chances of having an impingement. But the muscles that hold the scapula back are like your rhomboids, the middle trap, the lower trap. And so we don't tend to use we don't work out in the gym and use those much. And then too, we do a lot of forward activities. So we tend to get that forward head posture. We sort of slump a little bit. That makes the thoracic spine have more kyphosis, or more of a flex position, which makes your scapula rotate around the wall of the scapula, or it rotates around the wall of the chest wall there. So that closes down the space in the subacromial. So a lot of times the postural component has an effect on it. The shape of the scapula, the shape of the acromion does. And then if you have weakness or tightness in these muscles in the front, then that kind of predisposes you a little bit. But that space narrows down when you're in this 90-degree, from about 90 to 120 degrees abduction or flexion. And so, down in this area, you can work down around your waist level and it doesn't bother you. But when you start reaching up overhead, or say in sports where you're playing tennis or swimming or baseball, that kind of thing, then you start to see that.
Does this normally happen as you get older, like over time? Are you seeing that people are less likely to go, over that 90 to 120 range? And I'm assuming, being able to lift things overhead is such a big part of function,
Right.
in terms of like things that we want to be able to do in everyday life.
Uh-huh.
Are you seeing that? Are you seeing this type of injury with people who are aging and who haven't maybe done the exercises for their rhomboids, those middle and lower traps, things of that nature?
The impingement, you kind of see it in all age groups. Sometimes you see it a lot in athletes, because with athletes, especially if you're like a tennis player or a swimmer or a baseball pitcher, that type of thing, you're practicing hours and hours doing the same activity. And so you tend to overdevelop in certain muscles. And if you don't really strengthen the other ones, you can get the imbalance. Of course, on the opposite end, as we get older, we tend to sort of get that head forward position. The thoracic spine gets that kyphosis in it. We tend not to be as active sometimes. These muscles in the front shorten up, and then you can get some degenerative changes in the rotator cuff too. So a lot of times you narrow that space down normally just from the aging process a little bit,
Okay.
and it doesn't have to be, but a lot of times those rotator cuff muscles tend to get weaker unless you're on an active exercise program. So you see it in both areas. Sometimes on the younger patient, it's an overuse and it's an athlete, but then on the far end, you see it someone that might be a little bit older. Plus too, you can actually aggravate it by laying on that shoulder at night,
Mm.
or say you have a little fall and you fall and you put your arm out and you sort of tweak that rotator cuff and the bursa, and it gets inflamed, and then that sort of sets it off a little bit.
Okay, so I want to ask two questions here. And the first is coming from the angle of prevention.
Uh,
So, how can I avoid through exercise, through different functions, everyday
uh,
functions? How can I avoid getting shoulder impingement syndrome? And then my next question is going to be, if I have it, what are some of the things that you do with patients in order to reverse it
uh,
or fix it?
yeah. Probably in order to not get it, you know, anybody that's on sort of on an active exercise program, that sort of helps, because if you're inactive a lot and you're sitting a lot at the computer, we're not really doing a lot. These muscles shorten up tend to shorten up on us. And then what you typically see is somebody goes out and they do some gardening, or they do something, they're painting, or they're doing some reaching or lifting, and they sort of get the rotator cuff irritated, where if they had been on a regular exercise program over the years, they probably wouldn't see that happen as easily. Um, so, to be on some stretching, to stretch these muscles in the front, do some strengthening in the back, just a general routine that we
That's
would
interesting.
do.
So
Uh,
stretch here and strengthen
right.
your rhomboids and your traps.
Because these tend to be strong just because we do everything in front of us, and so
Right.
they're tight. So they pull the scapula forward, which narrows that space down, and then these in the back tend to get weak. And most people, even if you go to the gym, most everybody likes to work on the front muscles, because
Yeah.
those are the glamour muscles that everybody
Yeah.
sees when you're wearing a shirt. But nobody really thinks about the back much, and that's the real key on the shoulder. You want to balance, but we tend to sort of be overly strong, overly tight in the front, weak in the back, and then the other components feed in on it. So sometimes it can be just overusing something, working around the house, and then
Yep.
you sleep on that shoulder, or you have a little fall and you land on that arm, and then that causes the bursa to flare up or something. But it's usually a combination of things. But
Probably a combination of repetitive overuse
right,
and maybe like a specific incident,
yeah, exactly,
which could
exactly.
be a fall, could be like you're doing something that is repetitive and then you tweaked it, something of
Right,
that nature. So if
right.
that happens, what are some things that patients could expect when they come to see a physical therapist,
Uh-huh.
in terms of what are some of the things you'll put them through?
Most of the time, if you're having the symptoms, when I see a patient, they usually come in and say, "Gosh, my shoulder's really hurting. I'm having referred pain down my arm sometimes." And of course, you check them good to make sure it's not coming from somewhere else.
Yeah.
Sometimes you can have some neck issues that cause to have shoulder pain. But if you can get a good evaluation and sort of, there's special tests you can do to sort of see if it's going to be positive for impingement or rotator cuff. So that helps you have a pretty confident um, idea of what's going on. So if you think, if you know it's rotator cuff tendonitis, bursitis, or impingement, then you start to show them things they can do. Usually you'll try to stretch those muscles in the front. Try to start doing some strengthening for the rotator cuff, for the muscles that pull the scapula down. And then also you can use some modalities, things like ultrasound. You can do soft tissue mobilization, where you go in there and loosen up these muscles. Do some joint mobilization to the thoracic spine, because usually it's stiff and there's not a lot of mobility there. So you try to normalize everything. Everything that's tight, you try to stretch it and show them how to do it, because the key is having them go home and they know what to do. So that's kind of the biggest thing that I do, is try to instruct them so they understand why it's happening, and then that gives them control to know how to treat it. But the soft tissue things that I can do, they can't do themselves.
Sure.
Then you can see them and do the manual therapies and that type of thing, and that really helps. But then the ultimate goal is to teach them how to avoid it in the future.
How do you avoid it when it's some of these movements are such a big part of our daily life?
Yeah.
It seems, adding that balance component,
Yeah.
with some of these exercises that you're talking about.
Yeah. It's just really having a balance. If you look at the things we do, most everything we do is in front of us.
Yep.
If we're working on a laptop or we're watching TV. So, and if you look as we age, we tend to go forward. If you look at someone that's 20 years old and you look at them when they're 80, they're sort of bent forward. They tend to go forward. And the reason is because gravity is pulling us forward. So we tend to sort of slump that way.
Isn't there the saying that gravity's like pulling you towards the grave or something?
Oh, yeah, exactly. And
it's kind of gruesome, but
and it's one of those things we all kind of shorten up. Our posture changes a little bit. Of course, when it does, the shoulder, our scapula moves around the wall there, so that kind of lessens that space. But really, it's just a matter of having a balance. And so with it, you want to strengthen the muscles on the anti-gravity side, just like, and stretch the muscles in the front. That sort of balances out. So it's not anything drastic. It's just that most of these things come on over a gradual period of time. And then when you increase something or change something, then that sets it off.
It seems
sometimes
posture is just such a big deal in terms of aging.
It really is.
Like
it really is.
It feels like a lot of our physical debilitations come from. Really, I think it comes from, kind of the falling forward. Does balance have something to do with that too? I know we're getting off topic, but
yeah, everything kind of goes together. Our body, you can't separate one from the other, but the postural thing really has a big effect. I mean, a lot of cervical pain, a lot of lower back pain, a lot of hip pain. It all relates back to posture.
Yeah.
Same thing with our shoulders and things like that. So a lot of times those things set us up. It's not that you have pain all the time, but once you start to get to a critical level, then those things make a difference in there. So it's not, it's something we don't think about because it's so gradual, because our posture changes gradually over a long period of time.
Yes.
And you get used to it and you think, well, it's normal. But, if you look at a picture of yourself, maybe when you're 20 and you look at it maybe 20 years later and you're like, wow, I can tell I'm starting to get that little bit of kyphosis going on. And of course we all do a little bit, but really that's where if a person can be active throughout their life and have a balance. And then if you start having issues, if you start having some pain, don't put it off. Just go see, either go see a physical therapist or a doctor and let them evaluate you. And then most of the time, it's something you can treat. It's not a surgical case or anything like that. Now, with the rotator cuff, sometimes you can have an impingement syndrome that goes on, and they don't do anything about it. And you can develop a rotator cuff tear if you get enough friction in there. So that's why it's important when you start having symptoms. A lot of people say, well, I've had shoulder pain for 2 or 3 years and I didn't do much about it, but it got worse and worse. But if they had gone maybe and had someone evaluate it and treat it, they could have avoided that.
Can a tear like that, so you're saying a tear in your rotator cuff can be gradual?
Yeah, it can be more like a degenerative type of tear.
Okay.
And then it's the impingement is kind of a frictional. It's sort of a kind of a rubbing and an irritation, and the tendon gets flared up. You get a tendinopathy, and the tendon degenerates a little bit. And then if you do something, then it may tear there where it inserts on the bone. Of course, a lot of tears may be a sudden thing where you fall and you tear the rotator cuff or something, but you see a lot of degenerative type of tears sometimes, and it's sort of, people will say, I've had shoulder issues for a long time, and they'll sort of just, it'll be intermittent flare-ups, but they don't really deal with it, and then it gets gradually worse and worse, and finally, when it's really, really bad, they'll go to the doctor, then they've got a tear in there by then. So.
What are some of the symptoms, just so for the people listening, say, in their head, they're like, that sounds kind of like me. What are some of those? Is it just pain in the shoulder? Is there any other symptoms that they can be on the lookout? Because it seems like time is of the essence
Sure.
in
Yeah.
situations like
Yeah.
this.
Gosh, a shoulder pain can be really painful because the shoulder is innervated by the cervical nerve roots. So it has a real rich nerve supply. The same nerves are going down into your hand and fingers.
Mm.
And that's what gives our hand that ability to do the fine motor task is that rich nerve supply and our sensation in our fingertips and things. So the shoulder has the same nerve roots coming through it as that go down into the hand. So when you have anything going on with the shoulder as far as an inflammatory or an injury, those nerve roots are really irritated in there. So you have a lot of pain. So it's usually that sharp, piercing kind of pain sometimes.
Is it right on top, or would it
Well,
be?
the typical thing is people will say, well, it doesn't hurt here so much, it hurts here. It's in
Okay.
this lateral border. And that's kind of referred pain because the dermatome, which is the part of the skin that relates to the nerve itself, will be, most people will complain of this lateral shoulder pain. You can have pain in the joint too, but a lot of times the typical complaint is, well, boy, it really hurts down in here, sometimes even back in the shoulder blade area, that kind of thing. So
That's really
it's
interesting. So they can look out for pain like that, and then, you know, what if it's the person who's like, okay, maybe it'll go away, or I'm
yeah,
just going to take an ibuprofen.
sure,
Is there
yeah,
anything that you would encourage them to do, like right at that moment? Say they've been feeling it for a couple weeks. Do they need to get
right.
an evaluation, or could they, maybe do some exercises right then?
Yeah, the typical thing is, like we all have some aches and pains, so you
Yeah,
don't want to go to
yeah,
the doctor every time you have an ache or pain or something. But if you're having it and it's staying consistently there, and usually you'll know, like when you say you have to reach up in the cabinet to get a glass out, and when you go through that motion, you go, oh boy, that really hurts. Or you reach behind to put your belt on, you can't do it. Or you reach out to the side and you feel like, oh gosh, my arm is really hurting. That's probably a sign that you've got either the tendonitis, bursitis, maybe that impingement going on.
yeah.
So I would ice it, ice that shoulder maybe 2 or 3 times a day because that'll act as an anti-inflammatory. You can take ibuprofen. You can do some pendulum exercises that
Yep.
decompresses it, and that'll help you. But if it keeps coming back, then it's where you're constantly irritating it. So that's where it helps to go ahead and go to the doctor or go see the physical therapist.
At what point would you say it's like a chronic injury? Like after 3 weeks or after 6 months? How long are people going through life like this? Because
Yeah,
I can see myself kind of
yeah, sure,
adjusting my lifestyle so that
sure.
I don't feel that.
Yeah, sure. Most people do. A lot of times they'll have it and they'll say, it's been bothering me a couple years, and
Yes.
they'll say it does pretty good, and then I'll do something, and then I'll pay for it, and then it'll get better. So the typical thing is we'll go through that for a while, and then it gets to be where the time in between the episodes gets shorter and shorter. And then each
Oh,
episode gets a little bit more severe. So by the time they actually decide to go see the therapist or the doctor, a lot of times they're at that point where, boy, it's really bothering me now.
yeah.
Where it starts off as gradual and there's a big interval between the episodes. And then all of a sudden the episodes get more frequent and then the intensity of the pain gets worse with each episode. And then finally they go, okay, something's going on. So that's usually when I see them is then. So, but really, if they got it earlier, it would be better. But just human nature, we're all that way. None of us like to go to the doctor a whole lot or go see the therapist, So, but it really helps you if you can get an early diagnosis and
An early
treat it.
evaluation.
Yeah.
Yeah. Can you leave us with maybe just a couple exercises? It seems that such a big part of this is building up your back,
Right.
essentially.
Right.
Can you leave us, and then, I promise, I know you got patients waiting.
Yeah.
Can you just tell us a few exercises that people can try that there's no real risk of getting hurt with,
Sure.
but just to start to, get in the habit of not being so, focused
Yeah.
on your glamour muscles.
Sure. One thing that helps, that just helps decompress it is you can do some pendulums. And,
Yep.
I'm sitting here in the chair. I can't really do it well here, but if you're standing and you have an arm, you're kind of just do it in a clockwise direction, kind of letting it dangle.
And no weight.
And no, well, you can put a little cup weight around your wrist if you want to. You can do clockwise for about a minute, counterclockwise for a minute, and just gently swing it. But what that does is just decompresses it. It's not a strengthening. It just sort
Right.
of, it's more for pain relief. Uh, The other thing that's good to do is to do a wall corner stretch. If you get yourself in a corner and just put your forearms and your palms flat on the wall, walk into the corner and stretch the chest, the pec muscles and
Yep.
things there. That stretches those out good. And that sort
And
of,
that would have to help with posture too,
yeah,
because it opens you up a bit.
because those pull you forward,
Yeah.
and when you pull forward, you narrow down that space. The other one to do is just a simple isometric for the scapular retractors, the rhomboids, and it's just if you're sitting or standing, you're pulling your shoulder blades back together and holding them for maybe 6 seconds, and that pulls the scapula back, and then that opens up that space there.
And what might help with that, because you've put me through a lot of these exercises, is having a spouse, a friend, actually see if put your hand in the middle of their back and see if they're squeezing it.
Exactly.
Just so you can get some affirmation that you are activating
Right.
those muscles.
And the other one you could do if you have some TheraBand or TheraTubing or that kind of thing, is you could have some TheraBand coming from from a door handle or something, and you're going into external rotation.
Yeah.
And you try to strengthen the external rotators, because they're one of the rotator cuff muscles that pulls the head of the humerus down, which allows you to have more space in there. And those typically are the ones that are weak. And that's really those, the rotator cuff muscle, part of their function is to depress the humeral head or the ball part of the shoulder joint there, to actually pull it down and give you some space in there.
Interesting.
And so,
Ernie Dickson, man, this has been so fascinating. I really appreciate you talking with me about tell me again, shoulder impingement syndrome. Awesome.
And it's been awesome being here. Thanks so much.
Ernie Dickson, guys. He is with Elite Physical Performance. You can find him in Performance Medicine of Kingsport, in our Kingsport office. Guys, this has been Outside the Box. I rewatched this video. We went through a couple exercises that are super valuable. So hope you guys have a wonderful rest of your day. I'm your host, Ben Rogers. As always, we'll see you guys next time.
Don't go away.